Welcome to Unit 13, the Residence Care Plan. We're going to identify the purpose for the care plan, and the most important thing is to remember that it's a legal requirement. The Federal Nursing Home Reform Act, the OBRA 87 that we've talked about, and we're going to talk a lot more about, requires that a plan is developed for each resident with the involvement of the resident and the family. This is very important that we follow this legal requirement. It provides a way for the interdisciplinary team to plan consistent quality resident care as well as promote quality of life. For some residents, the care plan and associate documents are necessary for the facility to receive a Medicare reimbursement. This is extremely important. Some of the residents only have Medicare insurance, and so that's the only way that the facilities are reimbursed. So in saying this, for an example, they may get $2,000 to care for a resident. I'm just throwing a number out there. In that $2,000, that's everything to care for the resident. 24-hour nursing, pays for your job salaries, bed aid, a licensed practical nurse, a licensed vocational nurse. So everything that we use for that resident, their medication, their supplies, their laundry, their food, the maintenance of the facility, the electricity, all that is $2,000. And a lot of times their care exceeds that $2,000. So it's important for us not to be wasteful, especially with products and especially with our hours. We need to try to stay within our hours that we work and not go over and have overtime, because that's going to lose or take away more monies from what we get to care for that resident on a monthly basis. So please, remember that when you are caring for our residents out there. Next is the therapy department. The first one is the physical therapist, or the PT. A physical therapist evaluates they evaluate persons and develop a treatment plan for them. The goals are to increase movement, improve circulation, promote healing, reduce pain, prevent disabilities, and regain or maintain mobility. A physical therapist gives therapy in the form of heat, cold, massage, ultrasound, electricity, and exercise to the muscles, bone, and joints. For example, a physical therapist helps a person to safely use a walker, a cane, or wheelchair. Physical therapist education programs are offered at a 2-year degree level, a doctoring, and a master's. Entrance into these programs usually require an undergrad degree. The master degree programs usually last 2 years. A doctoral degree program lasts 3 years. Physical therapies have to pass a national and state licensure exam before they can practice in their specialty area. The occupational therapist, or OT, an occupational therapist helps the resident learn to compensate for their disability. The OT helps the resident perform activities of daily living, their ADLs. This often involves equipment that's called assistive or adaptive devices. For example, an OT can help teach a person to use a specific fork to help feed themselves. The occupational therapist observes a resident's needs and plans a treatment program. OT generally have an undergraduate degree before being admitted to a doctoral or master program. And the occupational therapists have to pass a national certified exam, and most must be licensed within their state. Next is the speech or language pathologist. A speech language pathologist helps with speech and swallowing problems. The speech pathologist identifies communication disorders, addresses factors that are in recovery, and plans a plan of care to meet the recovery goals. The Speech therapist teaches exercises to help the resident improve or overcome speech problems. For example, after a stroke, a person may not be able to speak or speak clearly. A speech therapist may use picture boards to help the person communicate thirst or pain. The speech therapist also evaluates a person's ability to swallow food and drink. The speech-language pathologists are generally required to have a master's degree in speech-language pathology. Most states require that they be licensed or certified to work. Next would be the resident and the family. The resident is an important member of the care plan team. The resident has the right to make decisions about his or her own care. The resident helps plan care and make choices. The resident's family may also be involved in these decisions. The family is a great source of information. They know the resident's personal preference, history, diet, rituals, and routines. So use the families to gather some information about the resident's likes and dislikes and how they like things. Remember, without the resident, we would have nothing. The resident is the whole reason why we have this care plan team, this map, to care for them. And the families are so important, like I said, because we can gather so much information from them to help us in caring for this resident in their everyday needs. So it is really important that you go and talk to them. Next, we are going to talk about the physical therapy, PT. A physical therapist evaluates a person and develops a treatment plan. Their goals are to increase movement, improve circulation, promote healing, reduce pain, and prevent disability, and to regain or maintain their mobility. A physical therapist gives therapy in the form of heat, cold, massage, ultrasound, electricity, and exercise to the muscles, bones, and joints. A good example of what a physical therapy helps a person is safety when they use a walker or a wheelchair. Physical therapist education programs are offered in a 2- and a 4-year degree, in a doctoral and a master's. Entrance into these programs usually require an undergrad degree. Master degrees programs usually last at least 2 years, and a doctoral degree program lasts about 3 years. The physical therapist has to pass a national test and must have the state license exam before they can even practice what they have been educated in. Let's see. Next would be the occupational therapist, or the OT. The occupational therapist helps the resident learn to compensate for disabilities. OT helps residents perform activities of daily living. This often involves equipment called assistive or adaptive devices. A good example of that would be an OT can teach a resident to use a special fork to feed himself. The occupational therapist observes the resident's needs and plans a treatment program. Occupational therapists generally have an undergraduate degree before being admitted to a doctoral or master program. Occupational therapists have to pass a national certification exam, and most must be licensed within their state in order to practice. Let's see. Next would be the speech-language pathologist or speech therapist. They help with speech and swallowing problems. They identify common communication disorders. Excuse me. And they address a plan of care to meet the recovery goals. The speech therapist teaches exercises to help the resident to improve or overcome speech problems. A good example of that is like after a stroke. A person may not be able to speak or even speak clearly. The speech therapist may use picture boards to help the person communicate, like their thirst or pain level. A speech therapist also evaluates a person's ability to swallow food and drink. The speech therapists are generally required to have a master's degree in speech and language pathology. Most states require them to be licensed or certified to work. Next would be the medical care provider, which would be the physician, the MD, or the DO. A doctor's job is to diagnose disease or disabilities and then prescribe medications. Doctors have a graduate from a 4-year medical school after receiving a bachelor degree, and then many doctors also take specialty training programs after medical school. And then, like DO stands for Doctor of Osteopathic Medications. Next would be the nurse practitioner, or the PA. Again, these usually require a nursing degree and 1 to 2, usually about 2 years extra of schooling. And they solely just work under the physician, and they're under their license. They're able to see patients, follow the care that the doctor has prescribed, and even initiate care and medication and treatments under the supervision of a doctor. There's other disciplines that may be represented in the developing of the care plan. It just depends on the individual resident's needs. Because again, it's all about what it takes to care for that patient in order for them to maintain the highest quality of life. Next, we're going to talk about how we are going to identify the CNA's responsibility during the care plan process. The first thing that you need to know is the minimum data set, the MDS. The minimum data set is a specific document that is used to guide the assessment or collection of information about the resident's life needs or functional status. This information collected is referred to as the data, and the data is collected from the time the resident is admitted to the facility till the time the resident is discharged from this facility. Each disciplinary team collects information that is specific to their education level. Like we talked about in the last slide, the CNA's responsibility with assessment is to make accurate and complete observation and report it accurately to the nurse. The CNA often provides input on the resident's ability to manage ADLs, activity of daily living. You need to remember you are with the patient the most. You're going to see them more than any of us in the team. So our eyes, our ears, our nose, our touch. So everything that you see that's different or feel that's different needs to be reported immediately to the nurse. Don't hesitate. Go with your gut. If you think something's changing, it's changing. So please report it as soon as possible. That's the step 1 in the care plan. Now we're going to talk a little bit about step 2. And this is the actual planning, the other care plan. The written care plan kind of becomes the framework that guidelines us to care for our resident. I like to refer it to as our map and how we care for our resident. It's developed by the interdisciplinary team members that we talked about and each one of their specialties. All the disciplinary teams get together and what's called a care plan conference, And in that care plan conference, we start writing the care plan, and it's got 3 components. The first one is we find a problem. With that problem, how we do that is we collect information through the assessment that we use, these specific questions and tools that we use to collect information about the resident. So we get that problem, and then we identify it. And your role in doing that is to participate. Tell us the problems that you see. After we have our problem, then we have the goals, which are also called outcomes. A goal or outcome is what we do, or is what the resident is expected to do. The goals may be stated as short-term within days, or a few weeks, or long-term within months. The CNA's responsibility may be to provide information about the resident's current status, so what's going on with them at that time. Then we use an approach, which is also called interventions. We define what is being done to help the resident achieve these goals, identify when the interventions occur and who and which department is responsible for them. And then the CNA may have responsibilities with specific interventions too to help our residents. Next would be the care plan process. This is implementation. It means putting the plan into action, the map of care into action. The CNA's responsibility is to know the problem and the goals of each resident they assist, and then how to follow the approaches or the interventions that have been identified to help them. Interventions could be assisting them to brush their teeth, oral care, or assisting them for a shower or a bath. How did they do that shower or bath? The problem we identified and the intervention we put in there to help them, did it help? The fourth process is evaluation. We always have to evaluate everything we do, and then we need to revise it if we need to. So is the resident achieving the goal that we put into play, or do we need to make some changes? The care plan is formally reviewed and revised on a regular basis. If the resident is meeting the goals, can higher goals be set? If the resident is unable to meet these goals, has there been a change in their functional abilities? Or is there another explanation why they couldn't reach those goals? What was it? We need to know. That's very important. Because we're going to have to modify these goals, or even put different approaches will need to be developed. So your role is to observe for changes and problems, and then report them to the nurse. And report them to the nurse when approaches or interventions cannot be carried out. They can no longer do things like ambulate down the hall or assist in giving themselves a shower. We need to know, because then we have to do the change the care plan. Because remember, if it's not in the care plan, we cannot do it. State's going to come in to make sure that we are following the care plan according to the state and federal regulations, according to OBRA. And if we're not, then we can get a deficiency in that, because the care plan is kind of our safety guideline too. It helps us to provide care for the residents safely, because it tells us what their problems are. That's extremely important that you remember that. So always report to the nurse the approaches and interventions that cannot be carried out. And observe for the progress in meeting these goals, and then report them to the nurse, because you are a very important member of the interdisciplinary team. Any information that you have that needs to go to the care plan conferences, please inform the nurse. There's not a lot of facilities that actually have the nurses' aides come to the care plan meetings, but we will ask for your input, because remember, you're our eyes, our ears, our nose, our touch. And your input is extremely valuable, because you do spend the most time with them. It's not me. I have 20, 30 patients to take care of. So remember that the care plan is the map to caring for our residents. Never do anything that is not in the care plan, and then report any new problems to the nurse, and any problems that we've identified that we can't meet their goals, or the goals are too easy, so that we can correct this care plan and make it truly the framework to caring for our residents safely. Well, congratulations. You have just completed this PowerPoint presentation for Unit 13. Please do remember how important this is. And remember safety. Remember to report things that are important to the residents' needs, so that we can get them in the care plan. I hope this helped to help you to understand what a care plan is a little bit more. Remember, without the resident, there would be no care plan. That's why it's important that we know that the residents and family are the most important part of our care plan for us in order to do a job that is safe for our residents.